Okay, let's go ahead and get started. So, welcome to the Transnational Vascular and Interventional Radiology Journal Club. This is our 35th session, and we're very excited to have you all here today. Just talk a little bit about what we're all about. So, we are an initiative to educate trainees on clinical research studies within the field of vascular and interventional radiology. We meet monthly and we focus on level one evidence. So we'll get started with our presentation here today. We have our two presenters, Isabella and Abbie. You can go ahead and take it away.
Hey everyone, I'm going to take a second and share the PowerPoint really fast. Okay, can everyone see that?
Yes.
Cool. So as she said, my name is Abbie. I'm a student at University of Missouri, Kansas City, and joining me is Izzy. She's also a University of Missouri, Kansas City student, and we are going to be presenting on the first study, which is a randomized controlled trial of uterine artery embolization versus focused ultrasound. Our mentor is in the crowd. He told us to call him Matt. So Matt, give a little wave.
Hi.
Um, and then, as you can see, the authors of this paper are listed on this slide. If it'll let me advance, there we go. Okay, so in this presentation, we're going to go through a little bit of an introduction, discuss the methods, the randomization process, the outcome measures or results, including the primary and secondary outcomes, have a little discussion, go through the conclusion, and then we'll show you our references, and then we'll have a question and answer session. So kind of to start off with an introduction, so uterine leiomyomas, also known as fibroids or myomas, they're essentially just benign growths from the uterine muscle. Common symptoms that you might experience with fibroids include the changes in frequency, flow, or duration of menstruation, pelvic pain, an enlarged uterus or abdomen, infertility, or miscarriages. So often fibroids are pretty small and they're only gonna, or they can occur in women who are nearing menopause, which those type of fibroids typically do not require treatment. But certain signs and symptoms are gonna warrant treatment, and those could include a heavy, painful menstrual period, which can lead to anemia or can disrupt normal activities. Bleeding between periods, we could have rapid increase in growth of the fibroids. Like I said earlier, pelvic pain, women could be experiencing infertility, but we could also be uncertain of whether the growth is a fibroid or some type of cancerous tumor. And so when we look at fibroids, we have some like kind of three categories of treatments that we typically go to. You have pharmacological, surgical, or alternatives. So your pharmacological include the oral contraceptive pills, your gonadotropin-releasing hormone agonists, your gonadotropin-releasing hormone antagonists with a hormone add-back therapy, your progesterone-releasing intrauterine devices, tranexamic acid, and then we have the surgical options, which include myomectomy and hysterectomy. And then what we'll focus on today is the alternative methods. So you have uterine artery embolization, also known as UAE. And then we have MRI guided ultrasound surgery, which is MRGFUS, or we're just going to call it focused ultrasound for today. And then radiofrequency ablation is an option. So you might be asking kind of why are we choosing an alternative versus the surgical options? Well, these alternative options are minimally invasive. You're typically going to see a shorter recovery time, will preserve the uterus, and we're avoiding some of those long-term risks that are associated with the other surgical options. For example, with a myomectomy, you always have an increased risk of intrauterine scarring, which can lead to infertility in women. And then with hysterectomy, obviously, we are removing the uterus, and so you are not able to bear children in the future. Now, when we were kind of looking at this topic, we realized there was not a lot of research comparing the effectiveness of UAE to the full ultrasound. There's a lot of research comparing like myomectomy to UAE or hysterectomy to the focused ultrasound, but not necessarily the alternative methods to each other, which is kind of what our study looked at. And so I'm going to pass it over to Izzy, who's going to give some description of what a UAE and a focused ultrasound are.
So, just a brief overview on UAE. It's a minimally invasive procedure in which tiny particles are injected through a catheter that is inserted through the femoral artery to the uterine arteries, and the goal is to block the blood flow, which results in fibroid shrinkage and symptom relief. So these next couple of slides will just go over the standardized treatment protocol that was described in the study. Starting with pre-procedural prep, patients were given moderate sedation along with anti-inflammatories and antiemetics, and a Foley catheter was placed and prophylactic antibiotics were given, and at some sites these were continued for 5 days. For vascular access, a 5 French sheath was inserted into the right common femoral artery, and a 5 French catheter was navigated into the left internal iliac artery, and from there into the left uterine artery. And once positioned, an arteriography was performed to map the uterine artery and confirm proper placement. And during embolization, tiny spherical beads were injected to block the flow. And if the uterus was large or larger, more embolic material was needed, larger beads may also be used. But before embolization, a final arteriogram was done to make sure the catheter was in the right spot and blood flow to the fibroid was visualized. So I just put a picture here to kind of help better visualize that. So here we have the catheter going into the right common femoral artery, and it would go up towards the aorta and down into the left internal iliac, which is called the crossover technique, and then into the left uterine artery. And after embolization on the left, the catheter would be pulled back and guided into the right internal iliac from the same access site. And either a Waltman loop or a Bookstein catheter could be used for this step. And then a final aortogram would check for other sources of blood flow, like from the ovarian arteries. And then the catheters were removed, bleeding was stopped with manual compression or vascular closure device, and patients were observed for about an hour in the recovery room or admitted overnight if they needed pain control. So, magnetic resonance guided focused ultrasound surgery, just a background on this. It uses high intensity focused ultrasound to heat and destroy fibroid tissue. And what makes this technique more unique is that it is done under real-time MRI guidance, which allowed for more precise targeted thermal ablation. And during the procedure, the patient would lie prone on a gel pad over the ultrasound transducer, which was built into the MRI table. And treatment sessions could last several hours depending on the fibroid size and number. And the procedure uses ultrasound pulses called sonications to heat the fibroid, essentially killing the fibroid cells without surgery. But if the temperature gets too high, it could cause cavitation, which is the formation of microbubbles that could lead to unpredictable tissue damage or less precise ablation. And to manage this, the system uses cooling intervals between sonications and alternates treatment locations to allow for time for the tissues to recover. And so in this study, the Exablate 2000 system was used with real-time MRI thermometry feedback and volumetric planning for precision targeting. Patients received light conscious sedation, had a Foley catheter placed, and were positioned prone over the water tank with a transducer embedded in the table. And I kind of put a picture of what that would look like off to the side. And a custom pelvic MRI coil was used for imaging, and degassed water plus a gel pad provided acoustic coupling between the patient and the ultrasound beam. So for pre-procedural planning, patients received a T2 weighted MRI and 3 planes to map their fibroids. And the ultrasound beam was about 5 millimeters wide and up to 35 millimeters long, with beam pass checked for safety. And the procedure would start with low energy test sonications to confirm targeting. And these are followed by 12 to 24-second therapeutic pulses with cooling intervals that would last up to 90 seconds. And then these were adjusted in real time based on MRI thermal feedback. And after the procedure, patients received contrast-enhanced T1 MRI to assess the non-perfused or the treated volume, and were monitored about an hour and discharged with escort. And then this is an actual picture of the machine, the MRI machine, and then the focused ultrasound transducer on the table. Patient would lie prone on undergo treatment. So I just included these. These are pictures from a different study done at UCSF School of Medicine that would look at focused ultrasound for uterine fibroids after treatment and before treatment. So in panel A, up in the top left, this is a T2 weighted pre-treatment image showing the uterine fibroids. And panel B is a T1 weighted pre-treatment image with contrast. And the fibroids are showing homogeneous enhancement here, meaning they're vascular and nesta tissue that we aim to ablate. And panel C on the top right is an initial post-focused ultrasound treatment, which is also T1 with contrast. And you can see that the anterior fibroid shows complete non-enhancement or no contrast uptake, and the middle fibroid also shows near complete non-enhancement. So these are consistent with successful ablation because if they're not enhancing, they're not receiving blood flow. So signs of successful ablation would be non-enhancement on T1 MRI with contrast, and the area that doesn't take up the contrast is called the non-perfused volume, or NPV, and a larger NPV would correlate with better symptom relief.
Okay, so kind of going into the objective of the first study. So the goal of all these authors was to report treatment effectiveness and ovarian function after the uterine artery embolization versus the magnetic resonance imaging guided focused ultrasound surgery. And like we said, it's called the first study, the fibroid interventions, reducing symptoms today and tomorrow study. So let's get into some of the methods. So overall, the study design was a comprehensive cohort. Initially, when they started the study, you're going to notice that they had a non-blinded randomized control trial, but as one arm. And then they decided to add another arm to the trial, which was a parallel observational cohort. So the reason they added this second arm to the trial was because there was individuals that met the enrollment criteria, but essentially they did not want to go through the randomization process. They wanted to know what treatment they were going to receive. And so they kind of added the second arm in. Overall, there was 57 randomized participants, and then there was 34 individuals that were within that observational cohort. Their initial target enrollment was 220 participants, but they only reached about 41% of that goal. And then I wanted to just include the inclusion and exclusion criteria. I'm not going to go through all of the exclusion criteria because you can see it's kind of a laundry list of things. But for inclusion, women had to be able to provide informed consent and they needed to be willing and able to attend all study visits. Additionally, they had to be premenopausal, either they had to be 25 years old or older, and they had to have no evidence of high-grade squamous intraepithelial lesions by Pap smear and/or HPV testing.
So the randomization was stratified by the uterine size and volume to ensure balance between both of the treatment groups, and this was done through a web-based dynamic system. And patients were treated within 10 days to minimize loss to follow-up, and the study was non-blinded since both the treatments are very different. So the two treatment groups were UAE and focused ultrasound. Um, Image analysis was done using MRI to assess for the number, location, and size of fibroids, and the uterine volume was calculated using the prolate ellipsoid formula, and total fibroid load was the sum of all fibroids larger than 1 centimeter. The primary outcome measured was reintervention for uterine fibroids within 36 months for symptomatic fibroids, and these could include hysterectomy, myomectomy, or repeat UAE and focused ultrasound. And secondary outcomes were onset of menopause, symptom and quality of life scores, pain assessment scores, sexual function, and ovarian reserve, which was measured using the AMH levels. And each of these were periodically measured at baseline, 6, 12, 24, and in 36 months via questionnaires or phone calls.
Okay, so now we're gonna kind of talk about some of the baseline data. On the right, you're gonna notice table 2, and then I've kind of put some red box the areas that I'm going to focus on. So if you'll look, you'll notice that the mean age between both treatments, being the UAE and that focused ultrasound, was about 44.4 with a standard deviation of 5. The population was made up of about 71% white individuals. The mean BMI was 27.2 with that standard deviation of 5.9. But you'll notice that between both treatment arms, they had similar uterine and fibroid characteristics. Although in that UAE group, they did have a higher total fibroid load. And then we've got the baseline data in table 3 that's more looking at the quality of life questionnaires. So we have the mean UFSQOL. So that is a uterine fibroid symptom and quality of life questionnaire, which is made up of two things. You have the SSS, which is the symptom severity score, and then you also have the HRQL, which is the health related quality of life score. So if you look at this table, you'll notice that the SSS score for both focused ultrasound and the UAE were relative pretty similar. So 53.9 versus the 53.1 with the same standard deviation of 19.8. The VAS and MPQ scores, which these are just pain assessment scores. So you can notice that they're higher in the focused ultrasound arm, except it was not statistically significant. And then going down to the FSFI scale. So the FSFI is a sexual function index. And so in both treatment arms, they had low FSFI, so low sexual function scores.
So among the 43 women in the focused ultrasound arm, 30% needed reintervention compared with 13% in the UAE arm. And following UAE, all of these procedures were hysterectomies. And then procedures following the focused ultrasound included hysterectomy, myomectomy, and UAE.
Okay, now we're gonna look at figure two. So on your y-axis, you have the cumulative incidence, and then on your x-axis, we have time since treatment. I'm gonna focus on the solid lines first. So the solid lines, we're looking at a competing event of menopause. We have the black line, which represents the focused ultrasound group, and then we have the red line, which is representing the UAE group. So you're going to notice that just looking at those solid lines, the focused ultrasound group had a significantly higher risk of reintervention compared to that UAE group. Now, they also looked at the competing event being the second fibroid procedure. And so we're going to look at the dashed lines. And again, black being the focused ultrasound, red being the UAE group. And so they noticed that the risk of menopause was really not significantly different between treatment groups. They had very similar mean age of onset. And although they did mention that the UAE arm did have a slightly earlier symptom onset. So the whole goal of this figure is just showing us that the ultrasound patients did have a higher cumulative reintervention rate, but menopause rates were pretty similar between the two groups.
So menopause occurred in 5 women in the UAE group and in 4 women in the focused ultrasound group, and all without needing reintervention. And there was no significant difference in menopause risk between the groups, and the average age of menopause was also similar, being 50.8 years for UAE and 49.3 years for focused ultrasound. So table 5 just shows the AMH values, which is a marker of ovarian reserve, and at baseline and then at the follow-up points of 12 months and 24 months between the two groups. So the baseline AMH for both groups was 0.3 nanograms per milliliter, and around 30% of women had undetectable AMH levels at baseline, meaning their ovarian reserves were already very low. And importantly, all 9 women who reached menopause during the study had an undetectable AMH at baseline. And this kind of suggests that it may help predict who's likely to go into menopause regardless of treatment. So when we look at changes in AMH over time, we notice that there's no significant difference at 12 months between the two groups, but at 24 months, there is a greater decline in AMH in the UAE group with an average of drop of 0.6 nanograms per milliliter compared to 0.2 in the ultrasound group. And even though this was statistically significant, the percent change wasn't, which suggests the difference might not be clinically meaningful. So overall, these findings support that AMH can be useful as a baseline marker, but that treatments themselves don't drastically affect ovarian reserve over time.
Okay, so now I'm going to go into table 3. Table 3 is a very large table, so I've kind of broken it down into multiple sections that we'll go through, and I'll try to break it down as best as I can. So on the left, you're going to notice we're looking at the UFS quality of life questionnaire, which, like I said earlier, that includes the symptom severity score in addition to the health-related quality of life score. Obviously, we want a symptom severity score to be lower with treatment, and we want the quality of life score to go higher. You'll see that we have baseline data, and then we have data from 6-month follow-up, 12-month follow-up, and 24-month follow-up for both the focused ultrasound and the UAE groups. So if we look at this table, we'll notice that we have improvement in fibroid symptoms and health-related quality of life by that 6-month follow-up, and that improvement persists throughout that follow-up period. In other terms, our SSS score for both groups went down with every follow-up category, and then our quality of life score increased with every follow-up category. You'll notice that each post-treatment time period, our UAE group had significantly better scores for both the SSS and the quality of life score for both all of the 6, 12, and 24-month follow-up compared to that focused ultrasound group. Again, table 3, different part of it. So now we're looking at the SF36 score. This is also known as the RAND Health Survey. Again, it's just like a general quality of life survey that they gave the participants. So we have a physical component to it, and then we also have a mental component to it. Like earlier, we have baseline 6-month, 12-month, and 24-month follow-up data. So you'll notice that there was significant improvement in the SF36 mental and physical scores at follow-up for both treatment arms. In other terms, this questionnaire, the quality of life, the scores went up. You'll notice at the 12-month follow-up, though, the physical and mental component measures were significantly higher in that UAE group compared to that focused ultrasound group. And then when we look at that 24-month follow-up, again, just the physical component score was significantly higher in that UAE arm compared to that focused ultrasound arm. Table 3 again. So this is now looking at the MPQ total score and the VAS score. Both of these questionnaires are pain assessments. So with treatment, we hope that these scores are going down. So you'll notice that the pain scores were improved for both treatment arms at 6, 12, and 24 months. However, in the 6 and 12-month follow-up, once they corrected they did a post-score adjustment for baseline pain scores. There was actually no significant difference between 6 and 12-month pain scores between the UAE and the focused ultrasound treatment. Table 3 again. So now we're looking at the SFFI, which is the Female Sexual Function Index. We're hoping that this score would go up with treatment. And when we look at the data, there is a similar improvement in sexual function at 6 and 12 months for the various treatment arms. And then what's kind of interesting is that when we look at the 24-month follow-up, you'll notice that the UAE arm, it actually kind of reverted back to the original baseline score. So we have 19.9 versus the 19.3, which was the baseline. Okay, now I'm going into a different figure. So this figure, I kind of broke it down into 2 components again. This is a univariate analysis. Essentially, we're looking at hazard ratios in 12 separate competing risk models, and we're looking at the risk of a second fibroid procedure with these variables. So I've highlighted in these red boxes. So first, we're going to look at age. So you'll notice that age, so the risk of reintervention decreased by 12% per 1 year increase in age. And then when we look at the anti-Müllerian hormone, you'll notice that the risk of a second fibroid procedure was 46% higher with a doubling of that anti-Müllerian hormone level. And then looking at the focused ultrasound versus the UAE treatment, the focused ultrasound had about close to a 3 times increased rate or risk of a second fibroid procedure. The baseline VAS or pain score was not statistically significant, nor was the total fibroid load statistically significant. Then we took the same table and they essentially did a multivariable analysis on it. So kind of looking at age, kind of like the single graph, but with the multivariate analysis, again, age, the risk for reintervention with an increase in age decreased by 11%. And then when we look at the anti-Müllerian hormone, kind of same trend. So the risk of reintervention went up by 40% with an increase in the anti-Müllerian hormone. And then when we're looking at when we're comparing the treatment, so the focused ultrasound versus the UAE, essentially when we had an increase in fibroid load, the focused ultrasound group had around like a 3.5% increased risk of reintervention. And then any category that I didn't highlight in red was not statistically significant. So overall, this is just kind of showing that age and anti-Müllerian hormone can help guide treatment planning, and that the anti-Müllerian hormone, or sorry, the focused ultrasound treatment carried a little bit of a higher long-term reintervention risk.
So figure 3 is showing the risk of reintervention or going into menopause over the course of 3 years. And the patients were divided into two groups based on AMH baseline levels. So panel A on the left shows baseline levels of AMH that are higher than 0.3 nanograms per milliliter. And on the left and on the right, panel B is the low AMH levels defined as less than or equal to 0.3 nanograms per milliliter. And the black lines represent the focused ultrasound group, and the red lines represent the UAE group. And dashed lines are risk of going through menopause, and solid lines are risk of reintervention. So on the y-axis, the cumulative incidence is the incidence of reintervention. And as you can see on the left on panel A, the risk of reintervention at 3 years was 56.9% in the focused ultrasound group and 23% in the UAE group among women with a higher baseline AMH level. But in contrast, women with a lower AMH level reintervention rates were much lower. There were about 22.1% for the focused ultrasound group and 0% for the UAE group. And also the incidence of menopause was higher. So this supports the idea that higher AMH indicates a higher likelihood of needing further treatments down the line, especially after focused ultrasound. And low AMH or low ovarian reserve may predict natural resolution of symptoms as menopause approaches. So for the discussion, reintervention was more common after focused ultrasound, and age and AMH were key predictors. Younger women and those with higher AMH were more likely to need further treatment, suggesting that AMH could guide treatment decisions. And AMH did drop more after UAE, which may explain why sexual function returned to baseline by 2 years before they received treatment. And all women who reached menopause had undetectable AMH at baseline. And then lastly, the fibroid number and size didn't affect outcomes. UAE does treat all fibroids at once, but even with the focused ultrasound's more targeted approach, the fibroid count didn't impact success. And both groups had lasting symptom relief and improved quality of life at 2 years, but only UAE patients reached levels seen in women without fibroids. And this was the first prospective trial directly comparing UAE with focused ultrasound. The comprehensive cohort design let patients choose their treatment, which made it more realistic than a strict randomized control trial, reflecting real life women's preferences, especially at a reproductive age. And the two main limitations were low enrollment and the use of an older ultrasound device.
So overall, the big conclusions that the first study made was that the uterine artery embolization was superior to that focused ultrasound with a lower risk of reintervention and a greater magnitude of symptom reduction. However, both UAE and the focused ultrasound did achieve significant short-term fibroid relief and low reintervention rates when women were older or had low anti-Müllerian hormone levels. And then here's some of our references.
An awesome overview, you guys. Um, you can educate me a little bit. How do you guys prefer for me to kind of run some questions and thoughts here? Um, just let me know what you guys normally do. I'm happy to draw out some questions or kind of talk a little.
So if anybody in the audience has any questions, now would be a good time to either unmute and ask them, or you can pop them in the chat.
Well, while we're waiting, since Abby and Izzy kind of spent this time to go through that, I'd love to hear kind of like what are your guys' take-home thoughts? Like, I mean, if you read this, so when reading the study, like what do you think you would tell a patient who asks you between the two? What would you do? Or maybe what do you think is better for one type of patient or the other?
I think, I mean, after going through the study kind of shows that the UAE is gonna be the preferred method over focused ultrasound. So I think, approaching the patient, one, I would see if the pharmacological treatment might be better, and then kind of go from there based on who the patient is, what their symptoms are, age and everything. But I think if I were given, UAE versus focused ultrasound, I would choose the UAE just because or decreased reintervention and a little bit better quality of life.
Okay, great. No, and then Izzy, any thoughts on your end?
Yeah, I agree with that. And now the focus ultrasound's a little less invasive just because there's no incisions being made, but and it's just a lot shorter recovery time. But ultimately, in the long run, if you're going to need a reintervention anyways, I think I would probably sway patients towards the UAE.
Cool. Yeah, no. So, I think you guys both brought up good points. So when you guys are talking about the reintervention rate, I think if your patient is the kind that's kind of stuck on the idea of like, I want to do like one thing, that's kind of something to point out. That's what I would kind of use as support doing uterine artery embolization because it has a lower reintervention rate. I will say that for patients that come in for uterine artery embolization, you're trying to find out what's bringing them there. And a lot of them have seen their OB-GYN, have had surgery discussed with them, and they want to do something that's minimally invasive. So I think it is kind of an interesting study because, although we don't offer high intensity focused ultrasound at UW currently, it is one of the technologies we're looking to get into more. You might find that patients hearing that you just have to lay down on a table and have this ultrasound kind of aimed at your uterus and your fibroids for 3 hours, and then then you can kind of see how the results are. Might find that appealing, whereas um, if they're willing to try to just do something that's most minimally invasive and then say, but you still have options afterwards. So you can still go to UAE, you can still go to surgery, but this would be kind of the most minimally invasive way. So that's kind of one thing to keep in mind. Because I certainly currently have patients at this point that, would like to do something as minimally invasive. As I mentioned to you guys in emails, I've had one patient who actually opted for the ultrasound at a different institution just because they wanted something just to try first before doing something. Even though we consider urinary embolization very minimally invasive, still patients are still wrapping their heads around it. So that's just kind of one good point to point out. Um, Now, about the anti-Mullerian hormone. Oh, let's see if there's some kind of comments here. Um, let's see. Did the paper suggest ideas of why the focus ultrasound had higher intervention rates and lower quality of life scores? Did it not fully treat the fibroids or something else? Um, Sorry, did you guys want to try to take that one?
Yeah, to be honest, they really didn't give us a reason why as to like why the UAE was, had those higher reintervention and or lower quality of life scores. So I don't think we can necessarily comment on that. Um, yeah.
Yeah, I would agree too. I don't think they really, I think I was really surprised by that as well. So like I mean, although the primary outcome was reintervention rate, which I think is a great kind of thing to address, a lot of the times with patients and you're seeing them at follow-up, you're looking to see if they're satisfied. And their satisfaction, I think is the most important thing, whether or not how much the fibroid shrinks. It's not necessarily what matters. Sometimes it doesn't go from, maybe it shrinks 20% and that's all they need to feel improvement. I think that is kind of also one of the things about the paper where it doesn't really talk about their primary symptoms. So if their primary symptom is bleeding, a lot of the times bleeding gets treated really well and effectively by UAE. Personally, just not sure how high intensity focused ultrasound, in terms of what is improved most rapidly with that treatment is. So there's a question about, so nowadays people tend to do hypogastric ganglion block to prevent extensive pain in patients. So was this considered in the study? So I think in the UAE, as you guys presented it, I didn't see it either. It's something I do for my cases. For those of you that don't know, well, and also probably in the study, what they don't talk about is kind of the peri or post-procedural pain or kind of how long that takes. So if you looked it up, the ultrasound seems like people don't have experienced much pain. I also say that most uterine artery embo patients tend to feel severe cramping for a while, to the point where we kind of counsel them that yes, it's a minimally invasive procedure, but we do all these things to mitigate it. IV Toradol during the procedure, the hypogastric plexus block that we do in the procedure. So in that, it adds maybe about 10 to 15 minutes to your procedure, or even shorter once you get used to it. Essentially, what you do is that while you have your catheter up and over, sorry if you can hear my dog, he's whining at the door. You can guide a needle into, what we think is the plexus. What I will say is that usually it's a structure that's triangular. When you inject contrast into it, it's non-vascular and it kind of disperses as you give the steroid. And then, and sorry, my dog is really sad he's not in the room. And patients do really well, and it helps kind of mitigate the pain for that. So it wasn't included in the study, and I find that it's really helpful for patient recovery. And it didn't seem like patient recovery was like a big secondary outcome for them.
Looks like Isaac asked any ideas on why reintervention after the UAE was hysterectomy, while there are more types of reintervention after the focused ultrasound. Um, Overall, I think when you compare like a hysterectomy versus a myomectomy, hysterectomy, you're removing the uterus. So there's no risk of the fibroid reoccurring versus with the myomectomy one, you can get scarring. In addition, some fibroids can reoccur. So my most educated guess would that be after doing UAE, a hysterectomy, you're kind of eliminating the opportunity for fibroids to reoccur and you're just kind of getting rid of the issue. Um, Izzy might be able to speak on why they had more types of reintervention after the focused ultrasound. Um, my most educated guess would be that focused ultrasound, the patients that typically get that, they had more symptoms, which makes me think that their fibroids were worse and maybe they were younger. I mean, so maybe they wanted to preserve their fertility before they went to hysterectomy, but that's a big reach.
No, I would agree with that. I think the focus ultrasound was, since it's more targeted, and UAE is more like a broader coverage of treating all the fibroids, and you're just like treating the specific fibroids with the ultrasound. I think maybe those patients were less like the next step for them if they chose that wouldn't be a hysterectomy, it'd be like a myomectomy or UAE before just removing the uterus, but it didn't really state any specific reason why in the article.
And then Alexander, are there any difference in cost or accessibility between UAE and the focused ultrasound? Um, I'm gonna say probably yes. So in general, Izzy and I, the hospital that we're at with UMKC is a safety net hospital um, in downtown Kansas City. And so one, we have a growing interventional radiology department, but they often don't you won't often see the OB-GYN department consult them on certain things just because of the accessibility to their team as they kind of grow the department. Also, our patient population at our hospital is a lot of underserved, uninsured individuals, and so the cost of the procedures has to be considered when we determine treatments. And so typically we're going to go towards more of the pharmacological treatments and then go. But I didn't honestly look up the exact costs. Matt might
I
be able
didn't
to
either.
speak a little bit more.
Yeah, I couldn't actually tell you the cost either, to be honest with you. I just don't know. In terms of coverage, I'm not sure how well insurance is covering focused ultrasound at this point yet, just because I haven't come into that situation. Uterine artery embolization is almost always covered by insurance. I haven't had issues for that. But just with newer technologies, you'll tend to find that it's different. Also, the devices and things are different. I'm assuming because you're going to be in an MR and it's going to take 3 or 4 hours and you need to be sedated for, it's probably a bigger cost. But I'm not exactly sure. Um, right. So sorry, on the comments, I saw something about, histotripsy versus uh, ultrasound. So a little bit is, yeah, because of the cavitation, as I mentioned. So they're kind of like a little bit different. But looks like the chat kind of covered that conversation. So I'm going to exit out of that chat. I would definitely say that
Almost.
accessibility is probably, like as I mentioned, places that don't offer it, you're not going to find it. Most places will be able to offer an uterine artery embolization, because it's just been around a lot longer.
Yeah, that was honestly one of the main reasons Izzy and I went for this paper, just because I have never seen either of these things. And Izzy, you might be able to correct me, but I don't think our hospital offers these. But if we were to go to um, our second hospital in the city that we can rotate at, which is a private hospital, I believe they might offer these more often to patients because they have the equipment and they do have the staff.
Yeah, I know we offer UAE, the second one, but I don't know if we offer focused ultrasound. I was looking it up to see where it was offered at, and it was honestly only like a handful of hospitals.
Yeah, for uterine artery embolization, in general, it's very similar to like doing postpartum hemorrhage treatment as well. So for those who do that or do pelvic trauma, it's easy something that you can translate those skills to. So you'll see that you know, I I feel like as an interventional radiologist, if you ask me like, is women's health one of my, passions or fields, like I don't think I necessarily came to it in that sense. It was more like, well, I've done training that's similar. I've done, pelvic embo for trauma. And, I think like, this is techniques that you can directly translate to that. So I think most interventional radiologists will be able to do that and offer that for you. So it looks like there's a question who had a patient present to their OB-GYN clinic on rotation for referral for laparoscopic focused ultrasound. Have I heard of this procedure? I have not. But I mean, there are some papers about percutaneous ablation of fibroids. It wouldn't surprise me if there's some kind of similar procedures where you do laparoscopic ultrasound and ablation for fibroids. I think everyone's there's different techniques, and I think the percutaneous approach one would be you'd kind of obviate the need for laparoscopic approach. But I guess they're potentially able to do that. Yeah, I think in general, like when you get patients who come to clinic for this type of situation, you kind of want to clarify what their goals are. If there's someone who says like I'm just I'm tired of this, I don't want to deal with this anymore. I think the right thing to do is really say like, have you had a chance to talk to your surgeon about this? Because you know by removing the uterus, like if you're okay with doing that, like that might be the answer you're looking for, because that kind of like Abbie mentions, like you don't have fibroids anymore if you don't have the uterus. But some patients don't want to do that, or there are some patients who want you just to buy them time. They're often in that perimenopausal window, like a lot of the patients were in this study. And if you can get them to a comfortable spot until they enter menopause and they're fibroids are no longer an issue, then that's good enough for them. And so trying to find the right solution to them is important, and kind of this is another thing in your toolbox of what you can offer. And then again, like your risk averse patients who don't want anything, your patients who are somewhere in the middle, and those ones who very much like just want to be done with this problem. I think you have to be open to having that conversation and seeing how they do.
Yeah, I was gonna mention that I was thinking maybe for the focused ultrasound, if a patient was very close to menopause, then it may not matter that the recurrence rate is higher. And you could maybe counsel them that it's more minimally invasive and apparently like potentially less painful. This might be a better option.
Yeah, from reading about it, seems like it's less painful. It just as an operator, I think your time is probably taken up more. It sounds like it takes longer on average than a UAE. So there is that component of it. And I guess in terms of, procedure, it's like I mentioned, like as you guys pointed out, they're laying on the MR table directing the ultrasound beams. It's not as, I guess, in terms of doing angiography, it might not be the exact same thing that you find enjoyment in doing, but I think it is something to offer patients.